So we're going to talk about financing care. First thing I always say at this point is we're talking about financing care, not oral health. And you all know this, that if you're thinking about the oral health of the population of kids, it's not just the care that's delivered, but it's all of the other factors. In fact, the vast majority, nutrition, education, genes, all the other things. But today, we're going to talk about financing care for kids. And I'm going to give you 2 seconds about background, because I never read the bios, frankly, in the thing, only so that you'll have a context to ask questions. So DentaQuest is involved in a lot of different things in terms of improving oral health. And that's our mission, to improve the oral health of all, everybody, every man, every woman, every child in this country. And we do it in a variety of different ways. So I was telling people at breakfast, I have the best job. I'm involved in the delivery of care because we have an oral health center, 15,000 patients a year, trying to practice in a prevention way, a model of best practices, doing R&D, very cool place. Involved in financing care because we're covering 18 million people. The vast majority are children, which is why I think Bert asked me to speak. We do a lot of Medicaid work. I think we are actually the largest provider of dental programs for children in the country. But that's not enough. We have a foundation, and we're talking again at breakfast about how do you think about grants and how do you think about using philanthropy to improve oral health. And then last but not least, we have an institute that looks at how do you improve the efficiency and effectiveness of the delivery system. So I say that so you can ask lots of different questions about how do you finance care and how do you finance and think about improving the oral health of all. And then before I get into the details, I always start with one thing. We'll talk about today. How does it work today? So you have a context to think about the future and where it might go. Then I am going to talk about the impact of the Affordable Care Act, not in gory detail. I have a huge advantage in talking about this, having lived, worked, and breathed for the last 6 years, essentially the Affordable Health Care Act in Massachusetts. So it was passed in 2006. 98 to 99% of our population in our state is covered. So it's an extraordinary sort of lab to look at. And the fun part, let's talk about trends, what we think might be happening in the future. So first question, before we get into the details. All money comes from one source. And we like to say, well, is this coming from government? Or is this coming from Medicaid? Or is this coming from CHIP? Or is this coming from insurance? Remember, it all comes basically from one place. Wages, income. It's coming out of somebody's pocket somewhere from what they're doing. So your taxes are funding Medicaid, are funding CHIP. You're not getting perhaps as high a wage because your employer is paying for health insurance. You are certainly paying for part of your health and your dental insurance out of your pocket, or you're paying the cost directly. So essentially, it is coming out of all of us. I'm going to change it so it's not just wages because, as somebody pointed out, it's income. Yes, if you are getting an income stream from something else, you're paying out of that. So let's talk about the system today. We've got, for children, coverage in a variety of different ways. One is families pay for their kids' dental care. And they either pay it because they're paying a premium that their employer is charging them, or they're paying for premium out of their own pocket, or they're paying for the co-insurance, the deductibles, the parts that's not covered. And about 19 million kids have no dental insurance. About 10 million have no medical insurance. So twice as many kids don't have any coverage for dental as have for medical. So family direct, they're paying for their kids' care. The private insurance market is divided into two, but I will tell you that 99, probably 0.9% of the people are covered through their employer, and you saw that in the presentation earlier. And I'm going to talk a little bit about why it's not in the individual market. So employers buy dental plans, they offer it to their employees buy it. It's generally subsidized by the employer. That matters. So I have a question. Am I allowed to ask questions of the group? Because we're giving this talk. Anybody have any idea what a family premium costs a year? What's that family paying? Guesses? Anything? Medical? No, just dental insurance. And about 90% of the people who have a medical plan have a dental plan. They have two different plans. For dental plan, how much would it cost you, family, 4 people, on average, to buy dental? It's about $1,500 a year. So for an average family, that's a big ticket item for dental insurance. And they're getting it through their employer. Individual market is almost non-existent. And the reason for that is, for dental insurance, it is, if it's not a mandated benefit, if it's not required, then you want to have dental insurance and it's costing $1,500 a year. When do you think it might be a good idea to buy it? When you've just been told you have a big bill. So for example, in our company, we get about, just in Massachusetts, I'll use that as an example, about 600 phone calls a month. We'd like to buy dental insurance. We say, that's great, individual plan, here's what it costs. It has a waiting period. Oh, I can't, I'm going tomorrow. Doesn't work like that. You can't, because it's not medical. Remember, people aren't worried about being run over by a truck. So they buy it when they need it, and then they can drop it. So think about that. I've just been told I have an expense, get the dental insurance, get it covered, drop it. Next month, told I have another expense, get the insurance, drop it. When you think about that Affordable Care Act and why there's a mandate, that's why. It doesn't work if everybody just goes in for a month, in and out, for when they need it. Actually, one anecdote. I had this lady who called me, and she gets it. She said, I'm so upset. I need to speak to the CEO. So I go, okay, and I take calls. So she goes, I want a dental insurance policy. And I go, yes, and we're happy to sell it to you. She said, but I can't have a waiting period. And I said, well, you know, blah, blah, here's why it works. And she goes, well, you don't understand. I want someone to pay for my dental bill. And I go, I understand exactly what you're trying to do. So you've got mostly in the group market where risk is spread. Keep that in mind when we talk about Affordable Care Act. And then as we've talked earlier, there are the two programs, the CHIP and the Medicaid program. Question?
How long is that waiting period?
How long is the waiting period? Generally, there's no waiting, actually almost always, there's no waiting period for the basic benefit of exams, cleanings, fluoride treatments, that sort of stuff. The waiting periods are things like crowns, ortho, implants, all the other services, where people really are looking for somebody else to pay the couple $1,000 bill.
And the waiting period is essentially to reduce costs for insurance companies?
No, the waiting period is because you cannot have a plan where people pay, let's say, $30, get $2,000 worth of benefits, and then leave. So it's the concept of risk. It would be like saying, my house burned down, I'd like fire insurance this month, and not pay in the past or the future. So it's the whole concept of insurance. So the question was, you know, why do we have a waiting period? Only in individual plans, because you don't have that risk issue in group or government plans. So now you've got the two programs we talked about earlier, which are the government programs, and about 30% of the children in this country are covered by one of those two plans. Okay, so we talked earlier, most private insurance is through preferred provider organizations. The insurance company negotiates a fee, a program with a group of dentists. The members agree to go to those dentists. They get a richer benefit package if they do, and then they go to other dentists. They still get some coverage. There are other types of plans. Just to make sure people understand, dental indemnity is just basically, it's what my mother had. You know, you collect all the bills in the shoebox, then you fill out a form at the end of the year, and then you get 80% reimbursement. It's a very traditional, old-fashioned type of either medical or dental insurance. And a dental HMO is just like the medical, where it's a much smaller group of people providing the care, and the person agrees to go to that place for all of their care. Discount dental drives me crazy because I don't think it's a plan. It just means, and you see them advertised all the time, you know, go to this place, buy this plan for $5 a month or $20 a month, and you get to see dentists at a discount because they've all agreed to accept a discount. It's not really a plan in that sense. It's just a way to, it's like a Costco card, I suppose. It's probably the best way to look at it. I'm going to do one sort of editorial comment. This is one that actually Bert and I have talked about a lot, which is we use the word dental insurance. It's somewhat of a misnomer, but that's the word in sort of the world. Dental is very different in terms of its history than medical. Dental didn't come about really until the 1970s. And the theory was sort of the opposite of medical. This is less, I am worried about being run over by a truck, and more, how do we get people to go in for the routine care, preventive services, so that they don't need the expensive services later on. So it was the reverse. The things that were all the prevention that in the 1970s nobody covered on the health side were covered at 100% by the dental plan. And then an expensive service, like a crown, was generally covered at 50 or 80% of the cost. So it was somewhat of the reverse, designed to accomplish a very different thing, to make sure, since the biggest reason people weren't going to the dentist, and still is they don't have the money, that that barrier was removed, on the theory that if you could get people in, good preventive services, and then at least help them pay for some of the things they might need later, that would be a better way to improve oral health. So it's a different design than medical plans, and generally are called dental plans, prepayment, different kinds of things. But I always find it interesting, the history of how things developed and the philosophy and the policy that went into it originally. So, Medicaid and CHIP are partnerships with the federal government and the state, which means unlike Medicare, which is the program for seniors, which doesn't cover dental basically at all, when you've seen one Medicaid program, you've seen one Medicaid program. So don't assume in your state, if you think you know Medicaid, that it's just the same everywhere else. Very, very different. So in terms of how children are covered, there are a variety of different ways. One is a very traditional, the state does it, they process the claims, they create a network, they're running like a little insurance program by themselves for Medicaid. And that's one model, and a number of states are still doing that. Another model for how dental for children is, let's take a look at outsourcing it to medical carriers. Well, a bunch of medical managed care carriers, and then have them do all the services, mental health, dental health, everything. And then some say, no, let's do it more like the traditional commercial programs where we have a dental program and we have a medical program. And then we'll outsource it to dental carriers. And then there are lots of pilots, so even in a state that says we are a managed medical carrier, we have pilot plans and projects. So the biggest Medicaid plan by far in the country, factor of huge, biggest state, so no surprise, California. California has about 6 million people in a very traditional Medicaid plan, but another 1 million people they're running pilots. Pay attention to this. This is really interesting. The pilot plans are growing by leaps and bounds. So how is the cost calculated? And this is something that I think is worth paying attention to because there are a lot of myths out there. So if you're kind to cover up with the cost of the plan, and you are the state Medicaid director, or you are the union administrator, or you are an insurer, then you look at two things. The first is what you pay to all the providers that are going to do the providing of care, and the second is all the services that are required to administer it. So I'm not going to go through all of this, but I'm going to say it is important to think about, because insurance, dental plans, they're different than, let's say, a coffee mug. Here's the coffee mug. If I put gold on it, I'll add $1. If I do something else, I take away $1. When I'm sitting there with our underwriters and actuaries, a very lively bunch, we sit around, and the first thing we want to know is, who are we covering? Vastly different if you're covering a population that has had insurance versus one that hasn't. If you're covering a population of children, where are they? How many are under the age of 1? How many are adolescents? Who are they? What areas do they live in? I mean, we actually look at, by zip code, who's in a fluoridated community and who's not. There's a difference in what it's going to cost to cover that population. We look at size of the network that we're going to put together of providers. If you cover all providers, then there's one utilization pattern. Then if you cover a group of select providers, different utilization pattern. What is the cost per unit? What's the methodology? I'm going to get to reimbursement methodology that you're going to use. Very important. Is it an optional benefit or is it a mandated benefit? If we come to you as a group of parents and we say we're going to offer a dental plan for children, and here's the price, we're making an assumption as to how many of you parents pick it. And this happens in unions a lot, or small employers. If 20% pick it, it's going to be one price. If 100% of the people pick it, much lower price. Because the people, if it's only 20%, are the people that know their kids really need it. So you're balancing all the time, all kinds of different factors, including the benefits. What are you going to cover? But it really is much more of an art and a degree of assumptions, and then you think about the trends because you're giving somebody a price for the future as opposed to today. Lots of things go into figuring out how to charge, because remember, all if it gets paid by somebody somewhere. So even if it's a state Medicaid director, they're trying to figure out how much of the Medicaid budget they're going to put in for next year for oral health for kids. And all of this goes into that kind of calculation. And then you have to look at the cost to administer programs. And that ranges, again, I'm mixing private and public, and there's a question.
Sorry, how would you explain how voluntary or mandated benefits affect the providers?
If you're looking at a program and it is a voluntary program, then be prepared for a sicker group of people. If it's a mandated program, then you're going to have what represents that population. So there'll be some that will need it, there'll be some that won't, some that are at high risk, some at low risk. But think of yourself, and it's just a group of parents, and it's going to be $1,500 out of your pocket. If you've got kids, and they are totally healthy, they haven't had a filling in their life, are you going to pay $1,500? On the other hand, if you have children who have high needs, am I going to think it's a bargain? So that's why it's such an incredibly important concept. And that, when people talk about this in the Affordable Health Care Act, well, why do you have to have a mandated benefit? All of us that have any kind of underwriting and insurance or actuarial go, well, duh, it has to be mandated if it's a guaranteed issuance. If you guarantee the benefits to everybody with no waiting periods and no pre-existing condition, you got to make it mandated. Otherwise, and actually this happened in Massachusetts, literally because there wasn't you could buy it at any point, people were signing up in the ambulance on the way. Oh, or the emergency room would say, hey, need insurance, good. And then they would drop. You can't do it that way. Massachusetts did it by having an open enrollment period and a mandate. I mean, they had to do both. So lots of different things you think about. There are lots of taxes that are put on your health plan. Affordable Care Act puts like a 2.5%, I think, on everybody's health insurance plan to fund it. That comes out of, ultimately, the consumer. Administration is an expense. If it's a private plan, brokers are the ones that are involved in selling it. So if you're in a small community and you're part of the Kiwanis and things like that, get to know your brokers as a provider, because these are the people that are influencing and thinking about who buys which plan in that community. There is something called risk, because you don't know the future. We just talked about all those factors. Who knows? They're trends, they're guesses. They're hopefully educated guesses, but they're still obviously risk involved. And then there is either some sort of hope that there's a profit on this plan or a contribution to reserve, because even in a Medicaid plan or a not-for-profit plan, I have a friend who runs a hospital who says it all the time, no money, no mission. You don't know the future. You have to make sure you have coverage for this. Okay, having done all of that, most purchasers do not buy a premium. State government, employers, et cetera, most of them are simply paying whatever the cost of the services are and some sort of administrative expense that's very low. I mean, literally, it's like $1 or $2. Most of them are simply paying services they come through. And when you think about reimbursement, which is very important to everybody, that matters. Keep that in the back of your head. So the benefits are designed not by the insurer. Gosh, I wish they were. I mean, I feel like we know more about what a good plan is than, frankly, somebody running a company. But they design the benefits, and the insurer or the plan says this. So when somebody says to me, why is there a deductible or why is there some sort of a maximum, I say, I agree, but not my decision. I can recommend, but not my decision. Same is true with the Medicaid programs. Those are generally designed by whoever's running it, and oftentimes, and I won't name names, but I've been in more meetings than I can tell you where everybody sits around a lovely table like this and says, that's really stupid. And we all go, yeah, that's really stupid. And everybody then says, yeah, we gotta do it. And that's a frustration beyond all belief. So thinking about how to change within it is very, very difficult. So mostly because of this sort of system I just described, it's a fee-for-service system. That's what people know. That's what they've had. You do a service, it gets paid. If you spend 3 hours counseling somebody, it doesn't. If you do something that is, it just grows out of all of this history and all of these pressures we just talked about. But there is a huge movement to change that. And that is why you see these laundry lists of different kinds of methodologies to pay. So you're a dentist, you're running a dental program, you're running a group practice, you're an individual people are going to talk about lots of different ways to get reimbursement. The most obvious is fee-for-service. I do a cleaning, I get X. Another one is a usual and customary. That's when the insurer says, well, on a usual basis, for the last couple of years, you've charged $100. But the customary in your community is $90. So we'll pay the lower, and can flip either way. It's still a kind of a fee for service. Relative value is a really interesting one, which says it's really your time. So if you spend, and actually I came out of the medical side, it came out of this sort of conversation one day where if you were a guy doing, cataract surgery and you were doing bang, bang, bang lots and you're making, a fair amount of money for every 30 minutes, and then there's some, person that's slogging it out for 3 days with a really tough delivery, that person, latter one, made nothing. So what's the relative value? How do you think about that? And it became very much time-based, time and skill-based. And that's how you got paid. Well, if you want to get somebody $100 an hour, then it really doesn't matter what they do. You're giving them $100 an hour. Interesting, sometimes used, not very much. Capitation, a fee for service, goes away, and you say, look, you're going to be responsible for a population. On average, we expect, for all those reasons, to have it cost $10. You'll get $10 a month, and if the person shows up and needs something more, you pay for it, and if they don't, they do less. It's, in theory, a good model. I think, personally, having lived in it in other lives, you have to have a very, very large population to make it work if you are the provider. Because if it's only a small percentage of your practice, thinking about it in a different way is incredibly difficult, and you can really get anti-selection. But I was in a home care company that did home infusion and everything else, and we were getting 34 cents a member a month. Now, I'm going to tell you, if you're doing home infusion on a chemo agent, it's a lot more than 34 cents a month. But if you're doing 34 cents a month for 3 million people, it all evens out in the end. Which leads me to this whole concept at the end of global payment, and that's the one people are talking about. That's in the Affordable Care Act. That's what you see in the newspaper. And 22% of us today are covered under some sort of a global arrangement. We don't even know it. It falls under all kinds of different names. And then pay for performance. Hate the name, but it really is sort of paying for incentives. If you do, if you get 70% of your high-risk kids fluoride treatment, then there's an incentive if you, have moved them up from 50% or something like that. Lots of different things. Happy to talk about, over lunch or whatever. Okay, so spectrum of provider payments. I've given you a sense of how they're going. If we start talking about future trends, pay attention. Pay attention to thinking about global payments, think about how to have incentive payments, think about how to do it in a very different way, because the move, and it's certainly accelerated by the Affordable Health Care Act, is to move away from fee-for-service. Only as a peek into the future, and it did not include oral health, which was interesting. In Massachusetts, just passed this year, having 6 years of the Affordable Care Act, essentially, has decided they're going to tackle payment reform. Their goal is to, within 3 to 5 years, get rid of fee-for-service for everybody. All contracts must be some sort of a quality contract, global integrated payment system. And they decided that, and I'm sort of laughing, other things will be covered first. How do you get mental health in it before oral health, for example? So lots of issues, but pay attention to the states of the labs in this country for what might be happening. So healthcare reform. I don't have to say it. There's a lot of stuff that was not done that should have been done in the last few years because people kept thinking it was going to go away. It didn't. There are two components. The part that everybody's paid most attention to is the insurance reform side. All the stuff that says you have to buy a plan, that kids under their parents' plan to 26 are now covered. All of that is what we've paid attention to. The other side, the delivery reform, is incredibly interesting. And I know there are, I think, 20-something things that impact oral health. Pilot projects, different kinds of ways of looking at things. But as you think about how the medical system is moving on the payment side, pay a lot of attention. Very basically, it simply says that everyone has to have some sort of health insurance plan. There will be essential benefits. We're going to have market reform. And this is what, in theory, the landscape will look like next year. Individuals and small groups. Small group defined as either 50 or 100 employees, so these are small, will have to either, by the way, the new word is marketplace. It's not exchanges. Have to buy either on a state or the federally facilitated exchange or marketplace, or they have to buy it off the exchange. There are grandfathered plans meaning they don't have to do anything until they change something. They're a large group, nothing's happening to them. And essentially, I mean, there's a lot, I shouldn't say nothing, lots of happening within government programs, but all the other government programs still exist. There's still Medicaid, there's still Medicare, there is still CHIP, there's still the Veterans Administration. So lots of conversations, but it's primarily for the next 2 years in the individual and the very small group market. But in theory, people will have to buy or have health insurance in some way, shape, or form. So how does dental fit in? It's ultimately, I'm going to say one other thing. Whatever you see in 2014 is not going to look like what will be around in 2015, 16, 17, and 18. It just isn't. It's going to go through lots of machinations, changes, ups, downs. Things are going to work. Things won't work. There'll be, and right now each state is implementing it very, very differently. Okay, so you have to have in that market right now, small and individual, a set of essential health benefits. There are 10 categories. Category 10 includes pediatric oral health benefits for children. Now, you might think the word essential means essential. It turns out that in the category of pediatric oral health benefits, it's not quite essential. Every state had to come up with a benchmark of what the plan would be. Most of them picked either the federal plan, which is FedVIP. Don't you love acronyms in this world? It's just FedVIP. Great. FedVIP is basically, and you'll like this, the plan that Congress has for itself and its employees and the federal employees. And CHIP is CHIP, which is, again, not the same in every state, but very, very comparable, very rich plan, good plan in terms of benefit design. The states went with CHIP. The states that said, I'm going to do my own exchange, this is a generalization, said, we'll pick CHIP. The federally facilitated exchanges picked FedVIP. Probably predictable. So what is a benchmark? A benchmark is a scope of benefit. It doesn't say exactly what it is. It doesn't say here's the deductible, here's the coinsurance, here's the frequency. It just says, okay, oral health exams must be covered. It doesn't say how. So remember that when we say benchmarks, it doesn't mean that means that there will be 2 cleanings a year and no more. And it just says they have to be covered in some way. So again, different plans will vary. And then there is a very interesting concept in the legislation called actuarial value. This made anyone who is an actuary or underwriter very excited because we were now involved, but nobody really understands actuarial value, what it means. And I'm going to get to it because it matters in terms of the dental benefit. So there are 3 ways that this oral health benefit for children can be offered on and off exchanges. It can be offered as a true standalone. I buy a health plan, I buy a dental plan on an exchange. This is the way, again, most people are buying. Over half the people that have a dental plan in this country have it either through Delta or Metropolitan, or in the private market, not the government market. 2 different plans. Neither of those cover medical, for example. And even when it's bought by a medical carrier, it's generally I buy a dental plan and I buy a medical plan. So standard policy, that's the way FedVIP works too. You pick one medical plan and then you pick one from a bunch of dental plans. Another would be you can bundle it. So I buy it like I buy, through Cigna, and I buy a Cigna Dental and I buy Cigna Mental. Or it can be truly embedded in a qualified health plan. Truly embedded, which means there's no difference in the benefits. Now, there are a million variations, so bear with me on this. But in theory, an embedded means if I buy a plan that has a $2,000 deductible for medical, it includes dental. So it really is embedded in just another service within a medical plan. Pediatric, however, has turned out to be defined as voluntary or optional on the exchange, and somewhat mandated off the exchange, but variations. This is the joy of this whole law. And what that means is, although it in theory is an essential benefit, if I buy it on the exchange or the marketplace, I'm still trying to learn after 4 years marketplace, if I buy it off on the exchange, I am Fay Donohue family, I go to the exchange, I look at the different plans, I say, okay, I would like to buy, Kaiser or Blue Cross or something for my medical, and it doesn't have a dental benefit, but I don't have to buy one, even though I'm offered lots of dental benefit plans to pick from. So it's totally optional. I could buy, if there was a plan, one that had dental embedded, but that would be a choice among many others. So it's not mandatory. Off the exchange, it's mandatory, and again, can be bought in a variety of different ways. This is somewhat illogical, I do realize this, that it's voluntary in one market segment and not on the other. Particularly if you're thinking of the underwriting, it's very illogical. Remember the conversation about selection at the beginning? So on the exchange, it will be, because it's voluntary, and the only people that can buy, presumably most of the people, not all, who buy it will be those that need it the most. It's a voluntary plan, so it will become more expensive, in theory, than off the exchange. That wasn't the intention. So this will only be there for a while, but that's the kind of world that we're living in right now. Very confusing. And I'm going to just spend a minute on actuarial value. On the medical side, you get to pick these brilliant metal levels, silver, gold. And what it means is each has a different price point. Actual value means price point based on what you, the consumer, have to pay versus what the plan will pay for the population, not you as an individual. Obviously, if you have a healthy year, the actuarial value is zero because you haven't used any services. And somebody who has had $500,000 worth of expenses, it's going to be way over 100 plus. But on average, each of these designs must hit a point where the consumer pays and the plan pays. It's slightly different for standalone dental because it's just for children. So to get that kind of variation, you'd have price points that are like $1 apart. So for children, it's a high and a low. Now, on the low, it says 70%. That means when we're sitting there designing a plan for children, these are children's standalone benefits. It has to be designed so the family is going to pay the actual value of 30% of it out of their pockets. The plan will pay 70%. How you play with the benefits, you can do lots of different things. You can sit there and say, which is better? If I have a deductible before anything is covered, and let's make it $100, in order to have a 70% actuarial value, then I have to have a very large out-of-pocket annual maximum. And out-of-pocket means all the money that I spend, and then after that point, the plan pays 100%. So you're just playing with the math. Now you're trying to do it in a logical way. Reasonable minds can differ. Some people would say, I think having a front-end deductible is high and a very low out-of-pocket max, and because I think those are the people that need it the most. Those are the people that are going to have the expensive ortho. Somebody else could say, well, wait a minute. I think the vast majority of people, you don't want to have any barriers to getting fillings or cleanings or office visits. Let's have a very low deductible, but a very high out-of-pocket max. But those are the kind of conversations that go about when one is creating this kind of a plan. Impacts the provider, because, and frankly, when we talk to the dental community, it varies too. Some practices will say, whoa, I want to have all the basic stuff covered. I want to make sure that I'm not arguing over a $40 sealant. Somebody else will say, no, I really want to make sure that the out-of-pocket max is as low as possible so that $6,000 treatment will be $5,000 to the patient instead of $5,500. So reasonable people can have interesting arguments, discussions over this, but that's the nature of creating these kinds of plans. Okay, payment reform. We talked a little bit about the other side, accountable care organizations, where you really are trying to put all the individuals together caring for a population and thinking about saying, how do we improve the health of this population? How do we do it at a lower cost? And how do we improve the patient experience? Because we want people to stay within our system. So all the incentives, in theory, are aligned to, and you've heard this, I presume, called the triple aim, and that creates that kind of an incentive system. In the ones that I'm familiar with on the medical side, because of the work that I do in the medical world, we would say, okay, I am hospital system X, you are Blue Cross, you tell me that I am going to cover on average, let's say, 5,000 patients this year for this system. And you're going to give me $2 million. And I am going to get paid fee for service along the way, but at the end we'll true up. And if it turns out that it's 1.9 million, we get to share it. And if it turns out it's 2.1, we get to share it. The difference between these accountable care organizations, is the patient doesn't know they're in the system. They don't know, and they're not locked in. They can go anywhere they want. So the way to make it work is to smother the patient with love, figure out what needs to be done so that they'll stay within your system, and manage their care in a very different way. And because you can do things differently, if you're a pediatrician, for example, and this is a real-life example in another state where it's a pilot project, and it includes an accountable care organization, and oral health is included. So oral health, and I can stand corrected on this because I don't remember exactly the numbers, if you take all the money for children that we spend in this country, well baby visits, children's hospitals, oral health, mental health, dental is something in the mid 20%. So when anybody says to me, dental's a rounding error, I go, really? A rounding error? It's less in the Medicaid population because you have a disproportionate number of really high and expensive kids in the Medicaid population. But in the world of children's health, remember, most money in this country is spent in the last year of life. Most money is spent on people that are both poor and old. So children are a smaller percentage. But oral health for the children, the money that we spend on children, is a very large amount. It is not a rounding error. It matters. So now I'm an accountable care organization. I've just been given the money for Medicaid for this population. Big population, it has to be big groups. Oral health is part of it. I care. I is not an insurance plan. I is not a Medicaid provider. I, generally the group of primary care physicians who are paying for all the other services getting involved. So now I'm thinking about it in a very different way. So this is a trend I would pay a lot of attention to, and thinking about it. Another one I'd pay an amazing amount of attention to is provider databases. Part of the Affordable Care Act and part of the Act in a number of states is that all information, all claims information from everybody who pays claims about everybody, not by name, is put into one database. So now the consumer has access. And access to prices by name of provider, not patients, obviously, name of provider, and access to information. So for example, in Massachusetts, I go to my children's pediatrician's office, click, click, click. I find out what it costs, so I know Dr. Ertel charges this. What percentage of Dr. Ertel's patients get vaccinated? Click, click, click. What percentage of Dr. Ertel's kids that have diabetes get the right diabetic care as the American Academy of Pediatricians says should happen? What percentage of Dr. Ertel's patients are referred to emergency rooms? Because, think about it, the power of the consumer. Just beginning. But think about it now in your world, as you think about going out. And I'm a group practice. That consumer has a lot of information. It is not coming from the insurer. It's not coming from, it's coming from all the claims databases, and it is agnostic. There's no good, bad, indifferent, although, of course, if you say, gee, only 40% of the high-risk kids in Dr. Smith's pediatric dental practice are getting fluoride, do I want to go to that practice? Do I not? So fascinating. Pay attention to this. It's coming. It's not there yet. I see a question.
Kind of backpedaling to the accountable care organizations, it sounds kind of a little bit like a capitation plan almost.
Oh, of course it is. You're absolutely right in some sense. It's just, instead of saying, I have a practice, and I did this actually on the other side, and I'm going to get, for this one contract, I'm going to get, 5% of my patients, I'm going to get $10 a month. I don't know how you manage that, how you think about it. This says in Massachusetts, for example, all of your income from Harvard Community Health Plan, from Blue Cross, from Medicaid, is all going to be put together with different kind of contracts. And now you've got a big population to manage, and it's not just you as one person. They don't ever give it to one. They don't give it to one doctor or one dentist. It's given to a system. Managed, however, generally, by a group of physicians, because the hospital is a cost center. Think about the mind bending. I'm on a board of a hospital. I used to measure and was passionate, and the CEO would come and say, great news, our beds are filled. Now he's supposed to come and say, great news, they're empty. No, that's not. Very hard to think about. Yeah. Another question.
Is there any kind of benefit where checkups, put your deductible lower.
Yeah. The question is, are there, sort of innovations in terms of benefit design so that somebody gets a reward if they go more often? Generally, they've been done a little bit of the flip, which is called carryover maximum. So if I go for the routine care and I don't use my annual maximum, most plans have, not Medicaid or CHIP, then I get to carry that over next year. So I'm banking money for future in case I need something. Generally, the reward is it's covered in full from the consumer's point of view. So I'm not. We haven't looked at it that way. There is one plan out there where people are getting things like points, frequent flyer miles. You get benefits. Same kind of a concept to encourage people to go. But a lot of debate about what is appropriate. Is it the 2 times a year? Well, you all know the answer to that. What do you want to incent? Do you want to incent the person who needs it 4 times a year and then the person who needs it once a year? That's what you really want to do. You want it to be focused. And that is a mindset change. You think that CEO has a tough time? Try to explain that to, my aunt and the consumers. I'm going to do one more anecdote on this one. So I'm talking to a group a number of years ago, and it was about second surgical opinions and how important it was, and it was a union group. And, here's the list of things you should get a second surgical opinion. And the guy stood up, honest to God, and said, I absolutely am not going to endorse this for our union. I fought too hard for the right to have unnecessary surgery. Okay. But it was that concept of, I can't change. This is what I want. My doc said my kid needs tonsillectomy, which is, the classic 40 years ago or 50 years ago. And, lots and lots of behavior change. Providers, payers, consumers. But, having had kids many years ago, the power of the consumer in changing obstetrics was stunning and very fast. So there is a lot of movement in this market. So that was the end of what I wanted to say today. Is there time for questions, or did I take up all my time? Questions? Okay, terrific. Keep talking. What else?
Hi, thank you for speaking today. Very informative. Given all the issues you've addressed today, what do you think might happen? What do you envision regarding the income of pediatric dentists in the coming years?
Great question. And when everybody says triple aim, all of us, remember where it all comes from? Wages? All of us go triple aim. Sounds good. Spend less. As a country, as a system, get better outcomes and a better patient experience. And all of us absolutely believe that. If you look at, where it goes, you will be spending less in a hospital, hopefully, and a lot more in prevention. If you are thinking about roles and responsibilities as leaders, which is this group that we get to talk to this morning, that leadership role within that, how do you think about it in different kinds of ways? What role do you play within that? So I think it's less than the income of a particular individual within new systems and thinking about it in very different ways. Because when I look at it, and that's why we started with a sort of a vision of how do you improve oral health, it's a broad need, huge. So it's less on the income of the individual, but how it's spent and where it's spent and what it's spent on.
Thank you for a great overview. I have 2 questions on outcomes. So if I was a purchaser and I came to you, employer, large employer, and I came to you and said, which type of plan would give me the best outcomes for my patient, or for my employees, okay, for children or for adults, and I would separate the 2. Because you had a slide that listed PPOs, capitation plans, direct reimbursement. I didn't see health savings plans on that slide. I'm not sure if DentaQuest has all of these services.
Yeah.
But which one would provide the best outcomes for my employees? Again, separating children from adults. Right. Which one would give me a better preventive mix? Do you have that kind of data? Can you give me that kind of advice? Which plan I should go with?
Yeah, first, I would love it if employers actually asked that, and Medicaid people ask that, and individuals ask that. Generally, the questions are, does my dentist participate, or my pediatrician, or my obstetrician, and how much will it cost? Are the questions. We're moving, and I wish, we talk a lot about it, but when it actually takes time to make the decision to thinking about population health, the health of my, whoever I'm responsible for, my big union, my Medicaid program, or my employee group. So the question on the table is, what would you tell somebody who comes to you and says, I'm responsible, I'm an employer, let's say, and I have 25,000 employees and families that I am worried about and thinking about. I would tell them that they, at this point in time, given the information they've got, would be best off in a preferred provider organization. You would be able to direct individuals to people who are actually credentialed. I kid you not, that matters, regrettably. There are people out there practicing who you probably wouldn't want to send your people to. So you want some sort of fairly rigorous credentialing, NCQA, you'll hear all these acronyms a million times. It drives me crazy, there should be one credentialing process, but anyway, somebody who's credentialed. You'd want to have a negotiated fee so that when I, the employee, since I'm responsible for you, go, I know that I'm getting and have negotiated a reasonable reimbursement for that, whatever it is that patient is going to have to pay part of. I want to be able to collect information, and this is the last speaker you're going to hear, and this is the part that really gets me insanely excited. Because now I want to be able to collect information and find out on a quadrant of quality, and this is not quality of the service. And when I talk to dentists, this is an interesting distinction. It isn't whether or not that, that margin is perfect. Quality is, of the high-risk kids, what percentage are getting X down to a different level. How many are going to emergency rooms? Huge, got lots of data on that, tons of wasted money. How many kids, we can go through all of the metrics that are being developed, and the, ADA is coming up with some terrific ones for children. That's what I would want to know if I was the purchaser. Are my children, or my families getting the right services at the right time? It's pretty simple. What I want as the person responsible for is the right price, the right service, the right quality, and I want the best outcome in terms of healthy people. And what I'd love to get to is a world where people are being measured on how healthy is the population, and for those who aren't healthy, how fast you get them down to good health. And that's coming in the next few years. The kind of information that you, the purchaser, are getting even this year compared to 5 years ago, and what you will be getting 5 years from now, is wildly different in terms of understanding. Question from Burton.
That's a really clear picture of where we're going. How are these folks going to get paid to deliver services with that eye toward outcomes?
That's why you're seeing so much in both the question is, how are you getting paid for outcomes? Nobody's getting paid for outcomes today. It's not happening. People are trying to move toward it, and they're moving it into system payments, they're moving it to global payments, they're moving it into quality, they're doing all kinds of pay for performance. So you start. Right now, the movement, for the most part, and this is dental and medical, is to pay for performance, which is a horrible thing, and it's not, I just don't like the name of it, but it's what it is. Where you say, okay, if you guys are getting your high-risk kids, 90% of your kids are getting fluoride, you're going to get more money. 40% of your kids are getting fluoride, you get less money. And it's, again, on a large group. So that's the sort of the first, you're going to go through phases, and I think that's the first. It's going to start with just pure information, because all of us know if you send any one of us in this room who are highly competitive, except, we want to do good, we want to do well. If you send something that said, hey, that team's at 40 and you're at 90, what do you think you are going to do? You're going to try to improve. So first is information, which you're not getting out of a practice management system in most cases. You can get out of big claims data, and then payment kind of follows that. So it'll be a process, just like that's why I had it in arrows in the slide. It will go through a variety of phases. Some will work, some won't, et cetera. And we're experimenting. One of the experiments is dental homes, along with medical homes. I think that's going to morph eventually to health homes. So we're trying different things. One of the reasons on Medicaid you see so many different pilots is because people are trying innovative things. So that's the fun of being around right now. This is much more fun. This is great. If you really care about oral health for kids, I can't imagine a better time to be starting, because you've got people willing to try things, new experiments, new ways of thinking, opportunities to work in teams and groups, to think about policy, think about care, think about what you have to do. Really, very exciting. The other will be, and this is how do we begin to change, you got to change consumers. We did some work with consumers in one area, First of all, and you know this, and this gets back to the data we were talking about earlier. Yes, my kids saw a dentist. Yes, they're in good oral health. And you look at them and go, no, I don't think so. And so it is, and yes, oral health literacy, yes, education, yes, training physicians, yes, how do you get them to refer people to the dentist when they're babies? Well, first of all, don't just look over their mouth, look at the teeth. So it's really getting the entire community, the whole community involved in thinking about how do you get kids into care, the appropriate care, and it's going to be very much experimental. But leading it will be fun, and that's one of the reasons you guys are here. Bert?
Thank you. Any
Anything?
more questions? Okay.
Great, thank you.
Fay, I want to thank you in particular for peeling back the very big lid of, I want to thank you in particular for peeling back the very big lid of the mystery of what goes on in the financing of dental care and all the moving pieces, and challenging people to think about how they might get paid in the future and what it is that they might be expected to be delivering and performing for children. So thank you so very much.